Wish you all very good morning. My talk is on digital pathology and AI in precision era. Thank you. Yeah. So as oncopathologists, what we do is whenever the patient comes to the oncologist, a biopsy or a resection is done of the tumor, and what we get in the laboratory is the tissue, and the final product of the tissue processing is the glass slide. And when we use whole slide imaging device to convert this glass slide into a virtual slide, that transition or transformation, we call it digital pathology. So when the pathologist actually sits on the microscope and offers diagnosis, in addition, the pathologist also gives information about how this tumor is going to behave, that is prognosis, how the tumor is going to respond to the treatment, that is prediction. And this transformation from glass slide to virtual slide itself provides considerable logistic, fiscal, and organizational challenges. And the virtual slide gets converted into, actually, basically, it's a grid of pixels. And so unit measurement of any picture is the pixels. So when we provide diagnosis on the basis of microscopy, we are giving superficial information to the oncologist about the grade and whether there are some certain adverse features. But there is a lot which is hidden beneath, which is much beyond, much deeper, subvisual information, and that is abundant. It is distributed among different cell types, different cell layers. There is spatial context provided by digital pathology. And now in this era, we have ability to perform precise analysis of large data sets. And this is called computational pathology. And whole slide imaging, that is digital pathology, is an enabler of computational pathology. So after this introductory part, let me come to the applications of digital pathology. They are myriad and can be classified into clinical research and education. In the clinical segment, there is, once we have virtual slide, we can use it for primary diagnosis, second opinion, computer-assisted diagnosis, remote frozen section support, multidisciplinary tumor boards or quality assurance purposes. Education is the most popular use of digital pathology in India and in the rest of the world also. And there is something which I have kept in research, but it has already reached clinical space, that is AI and deep learning. So this is what I was saying. We convey traditional parameters to the oncologist, but there's a lot of information hidden beneath, and that is distributed in the tumor microenvironment, molecular alterations, stromal interactions, immune contexture. And so this brings me to pathomics, which is basically a combination of digital pathology and AI. And this actually helps us mine that wealth of information, which is in the form of millions of data points. And this is the right combination which can be used for precision oncology, which is basically personalized cancer care approach that uses patients' unique genetic, molecular, or cellular tumor characteristics to guide diagnosis, prevention, and targeted treatment. So coming to applications of AI in pathology, we use it for screening lymph nodes for metastasis, quantifying immunohistochemical expression, segmenting, counting mitosis. Pathologists in the audience would agree with me. We actually perform various repetitive, mundane tasks in our everyday practice. That role can be definitely taken over by AI. Then grading assist tools, predicting genomic, proteomic outcome information from H&E images, and the last is histological quality control. So these are, I'll be giving certain examples of breast cancer, prostate cancer, and basically describing use cases. So this is about quantification of immunohistochemistry in breast cancer case. This is a routine marker which we use for breast cancer. And this case, whatever information we give, this gets translated into the treatment. This is HER2 estimation, and this is KI67 estimation, which is actually a very difficult exercise for the pathologist, but it is made easier by use of AI algorithm. And the importance of this slide is, most important is validation of any AI algorithm. So before we replace our routine practice with AI algorithm, this is the most essential part. And not only immunohistochemistry, wherever quantification is required, we can use AI algorithm. This is about quantification of in situ hybridization. Yet another example of breast cancer, and you will agree with me, with virtual image, it becomes agnostic of time and person. So you can basically be anywhere in the world and you can report these cases. This is about lymph node metastasis, and again, we validated against human observers, and needless to say, this is the understanding, this is about understanding AI limitation, that post-chemotherapy evaluation of lymph nodes was much better done by human observers than the AI algorithm. Coming to whole slide imaging as predictive biomarker, in small breast cancers, which are strongly ERPR positive, what we do currently is we run very expensive oncotype DX test, which is a multiplex molecular test, to determine whether this patient will require chemotherapy. And excuse me, I need water. Let it be here. Yeah. So what we do is run a very expensive molecular test, which is Oncotype DX test. And the cost of this particular test is equivalent to one chemotherapy cycle. So we can basically run the slide under whole slide imaging system and get the get some answer from that. And that's what we did. That is image-based risk scoring. And we have shown that that added much more prognostic value to Oncotype DX risk categories. And whether we do IBRIS or we run this molecular test, what we are basically deciding is this particular patient needs chemotherapy or not. And this work was published in Nature Portfolio Journal Breast Cancer. There are several such algorithms in the commercial space. Now there is another new entity which is called HER2 low breast cancer, and there again we are supposed to make distinction between HER2 0 plus, HER2 0, HER2 0 1 plus. Again, it is a very difficult proposition, and there are many AI algorithms which are coming into play. And this is one interesting paper where they have avoided the intermediary step of immunohistochemistry, converted H&E into virtual stained IHC image of HER2, and then gone ahead with the applying algorithm and then deciding whether it is HER2 low or not. So there are several commercially available algorithms in breast cancer, and they help us to prioritize cases, to decide about IHC ordering, provide cancer heat maps, grading measurements, non-cancer findings, AI-driven reporting. Coming to prostate, this is yet another AI success story in Europath. It was Page AI. It was the first FDA authorization for AI in pathology in 2021, and it was the example of assistive clinical grade AI for prostate cancer diagnosis. Now coming to multimodal kind of AI algorithm, this is one excellent example, that is Artera AI prostate test, which is AI-powered, FDA-cleared NCCN guideline included prognostic or predictive test, which is used for intermediate grade prostate cancer patients, again localized prostate cancer patient, whether they should go for any particular drug or not. And this again combines pathology, clinical data, and in addition, there is yet another test which combines molecular information, clinical information, as well as pathology, which is derived from whole slide imaging. Coming to novel computational pathology-based biomarker, that is trophoblast cell surface antigen 2 for lung cancer patients. This is called TROP2 QCS, that is quantitative continuous scoring normalized membrane ratio biomarker. This is basically demonstrate presence of TROP2 on the cell membrane relative to cell membrane and cytoplasm. And it has been shown that patients who are TROP2 positive, they respond better to antibody drug conjugate. And this is going to be the first computational pathology biomarker for predicting clinical response to Dato-DXd in non-small cell lung cancer. So the latest update is combine data from which are present in various silos, bring them together and make sense out of it. And then coming to tumor microenvironment, immune axis, the basic challenge in routine practice is translating histological appearance into accurate reproducible risk stratification, because there are too many cells which are present in tumor microenvironment, too many in the immune axis. And so here AI definitely helps. Here there is combination of AI, spatial biology, and tumor microenvironment. And the key application is to predict immunotherapy response in cancer. Coming to generative AI in anatomic pathology, this is used for image analysis and enhancement, synthetic data generation, diagnostic support, workflow efficiency, education and research. And this is an example where Model AI generative AI co-pilot Pat Chat received FDA breakthrough device designation in Jan 2025, and it has potential to transform diagnostic workflows and improve patient outcome in pathology. So these are range of current applications in path: morphology, IHC quantification, workflow improvement, whole slide imaging as biomarker, molecular prediction, and of course, education and training. What is pathologist's role in algorithm development? To basically participate in the design itself, to educate, train, development team, cohort curation, and most important is clinical validation. Coming to cancer imaging biobank, many of the limitations which were discussed in the previous talks can be dealt with by cancer imaging biobanks, and this is the AI-enabled transformation of histopath workflow right from receipt of the sample to final sign out. Thank you very much for your patient hearing.
Thank you very much, Dr. Sangeetha. That was very good insights and knowledgeable on digital pathology and know about the AI role. So we're going to have one question from the audience.
Any one question, and make it quick in the interest of time. If not, sirs, you'll have to ask a question. Yes.
So the AI and the pathology, what I've been seeing, there is a lot of vacuum because you need to collect a lot of data and keep that in ready. Any light you can throw on it, how that vacuum can be filled? Because without which, the precision can't be, acquired.
I didn't understand which vacuum you're talking about.
See, whenever the application of AI has to be done on pathology, we need to have a lot of data backup.
Yeah, so in PATH, the data comes from whole slide imaging system. In PATH, the data comes from whole slide imaging system, and to make better sense of it, the clinicians have to put their clinical data again into the system.
So
right?
So
you can stitch the information and make sense out of it.
Thank you very much, and thank you for, we have one question. The last one, 1 minute please.
For oncologists, so we always rely on a frozen section for tumor margins. Is it really helped you in your experience for the assessment of margin?
More than AI, there is new technology which is called it's direct imaging. Right from tissue to straight away you get the image. There is no in-between processing. And that particular technology is under investigation. And but digital pathology as telepathology can very well be used at this juncture also for any center where there are no pathologists available. So that is already in clinical space.
Because these days the patient's attenders, when we remove the tumor and we'll show to the patient attender and then we'll send for frozen section, they're simply clicking the photo and just giving onto the AI and what are the possibilities they're asking. And it's, of course, it's giving multiple, last week we had a case of borderline ovarian tumor. It got uploaded and it is given as a high-grade serous carcinoma, second possibility mucinous adenoma.
Which
So,
AI algorithm are you using for it?
not for me, that the patient attenders were using that. They are using the chat GPT. So
Which is highly inaccurate.
yeah,
That's the reason why I talked about validation.
yeah.
The thing is that this is just 13 minutes talk and this topic is for 3-day conference. Okay, so you really cannot make justice